Hello, my student ID is U3258476, and today I'll be doing a presentation on transcranial magnetic stimulation in the treatment of obsessive-compulsive disorder. Obsessive-compulsive disorder, commonly referred to as OCD, is a psychological condition that impacts an estimated 1 to 3% of individuals across their lifetime. It is commonly identified by prolonged eruptions of ego-diagnostic thoughts, impulses, or images, as well as involuntarily grouped repetitive or ritualistic behaviors that can create an overwhelming compulsion to alleviate distress. Often, these immensely time-consuming urges give rise to socio-occupational dysfunction in one's daily activities. A diagnosis of OCD under the DSM-5 requires that either the obsessions or compulsions are present and time-consuming, taking more than an hour per day, as well as an inability to explain the symptoms under the standard of another psychological condition. Considering that OCD frequently co-occurs with other psychiatric disorders, such as major depressive disorder or generalized anxiety disorder, the requirement for a comprehensive screening and treatment cannot be overstated. While current management strategies have favored pharmacological approaches such as serotonin reuptake inhibitors, psychotherapy by means of cognitive behavioral therapy, or an interplay of both, almost 40% of patients remain unresponsive, prompting the need for alternative treatment solutions such as the neuromodulation method of transcranial magnetic stimulation. TMS utilizes a stimulating coil placed on the scalp to create a transient magnetic field that subsequently enters the surface of the brain, in turn inducing an electrical current. The procedure parameters of TMS can have different effects on cortical excitability by modifying the type and orientation of the coil, the interspace between the coil and the brain, as well as the strength, frequency, and pattern of stimulation. TMS operators often use a figure-of-8 coil, which comprises of a pair of adjacent circular loops with current flow in divergent directions. The induced electrical field flows into the patient's brain, creating two vortices that merge at the center, allowing for the delivery of a more localized stimulation. Notably, low-frequency pulses of less than 1 Hz are inhibitory, whereby it dampens neural activity to the underlying cortex, while high-frequency pulses of more than 5 Hz are excitatory. Repetitive transcranial magnetic stimulation has gained interest from researchers, as there is an extensive array of randomized control studies using rTMS in the mitigation of symptoms in depression and schizophrenia. However, its therapeutic effect on OCD has been less distinct. Regions such as the dorsolateral prefrontal cortex, the supplementary motor area, and the orbitofrontal cortex have all been emphasized. Research on rTMS-based interventions for OCD centers principally on the dorsolateral prefrontal cortex. Accredited to Greenberg et al. 1997's trial of 12 OCD patients, rTMS was conducted at a 20 Hz frequency for 2 seconds per minute for 20 minutes. The authors targeted the right lateral prefrontal, the left lateral prefrontal, and the mid-occipital sites. The results exhibited clear support for the use of rTMS on the right lateral prefrontal, considering there was a slight reduction in compulsions for at least 8 hours following treatment. These findings were echoed in a subsequent study that examined low-frequency rTMS over the right dorsolateral prefrontal cortex. Elba et al. In 2016 suggested that OCD can be attributed to increased neural activity in prefrontal subcortical circuits, and the optimal intervention would be an inhibitory rTMS protocol. The trial evaluated 45 patients randomly assigned into 3 test groups. The first group received 1 Hz, the second 10 Hz, and the final group received sham stimulation. All groups were tested at 100% of the resting motor threshold for 10 sessions, and the findings demonstrated a strong quantifiable relationship between low frequency to the right dorsolateral prefrontal cortex and modulation of hyperactivity of corticostriato-thalamocortical circuitry. Despite this, a significant portion of opposing literature undermines the applicability of both low-frequency and high-frequency rTMS to the right dorsolateral prefrontal cortex. Most notable was Alfonso et al. 2001 study of 18 OCD patients, whereby either real or sham rTMS of 1 Hz frequency was applied for a treatment period of 20 minutes over 18 sessions. Contrary to the findings of Alba et al. 2016, this study failed to prove an effective change in real rTMS compared to sham. However, it should be acknowledged that the extent to which the trials can be compared is limited, given the one study had fewer participants and there was a differentiation in the type of coil used. Sarkar et al. 2010 assessed the impact of adjunctive rTMS to 42 patients by randomly assigning 10 sessions of add-on rTMS at 10 Hz compared to a sham stimulation. Patients were rated on 4 OCD scales at the baseline, day 14 and day 28, and eventually the authors observed that adjunctive high-frequency right prefrontal RTMS was ineffectual for OCD. It should be emphasized that the presence of an anti-obsessive drug remained consistent throughout the duration of the trial, which possibly altered its RTMS validity when compared to trials without adjunctive intervention. The aforementioned findings are congruent to research on the left dorsolateral prefrontal cortex, when in Prasco et al. 2006 applied 10 sessions of 1 Hz compared to sham in 33 serotonin reuptake inhibitor resistant OCD patients. They were all assessed prior to treatment, immediately after, and in a subsequent 2 weeks, and in line with the previous studies, the use of RTMS was not a central contributor to improving OCD on account that both groups improved uniformly. Although the dorsolateral prefrontal cortex dominates the exploration of RTMS, various other regions of the brain, such as the supplementary motor area, have shown more consistent improvement in clinical trials, given the potential hyperactivity in some cortical areas. Initially assessed by Mantovani et al. In 2006, the authors implemented RTMS to the supplementary motor area for 10 daily sessions at 1 Hz. On 10 patients with OCD or Tourette syndrome, they concluded that following 2 weeks of daily RTMS, there was a notable reduction on both symptom severity tests. One concern in this trial was that the groups differed in baseline brain excitability measures. A lower motor threshold in the right hemisphere of patients receiving RTMS could have predisposed them to being more receptive compared to the other test group. Moreover, Raffini et al. In 2009 examined the effect of 10 minutes of 1 Hz RTMS for 15 sessions to the left orbitofrontal cortex in 23 diagnosed drug-resistant OCD patients. Following symptoms assessments at the baseline at the end of the treatment and once every 2 weeks for 3 months, it was concluded that RTMS marked a decline in symptoms in comparison to sham for 10 weeks after RTMS, with a loss of significance after 12 weeks. There was also a marginal reduction of anxiety and depression symptoms that was consistent between the two groups. A comprehensive review of the literature necessitates acknowledgement of the potential adverse effects of RTMS. All of the aforementioned studies provided no indication of harmful complications such as seizures or complaints about memory or concentration, albeit there was an indication of headaches in 2 studies, which was resolved within a few hours or up to 2 weeks. A further point of contention in RTMS is its non-viability on OCD patients with a history of seizures, epilepsy, or head injuries, as well as mobile metal implants, implanted metal pumps, or metal clips placed inside the skull. Consistent with 2 extensive reviews led by Lefaucheux et al. 2014 and Saba et al. 2015, the present body of work on RTMS for the treatment of OCD is insufficiently uniform for a precise comparison. The small sample size of less than 20 patients in majority studies raises considerable doubts about the generalizability of their findings. A potential explanation for the disparity is the differences in designs, RTMS parameters, and outcome measurements. Further standardized and placebo-controlled research should be pursued using larger sample sizes and more homogeneity in terms of clinical variables, stimulation parameters, and cortical target. Thank you for watching this presentation, and the following slides will be the references used.